Antilymphocyte Globulin for Prevention of Chronic Graft versus Host Disease. Definition: Chronic graft versus host disease (GVHD) is the leading cause of later illness and death after allogeneic hematopoietic stem cell transplantation. Pros: we hypothesize that the inclusion of antihuman T lymphocytes immunoglobulin in a myeloablative conditioning regimen for patients with acute leukemia will result in a significant reduction in chronic GVHD 2 years after allogeneic peripheral blood stem cell transplantation from an HLA identical siblings.
Allogeneic hematopoietic stem cell transplantation is a widely used treatment for leukemia and other bone marrow disorders. In patients who receive this therapy, chronic graft versus host disease is a leading cause of late morbidity and mortality. Researchers hypothesized that giving anti-human T lymphocyte immunoglobulin, or ATG, as part of preparation for transplantation would decrease chronic graft versus host disease. But would it result in more infections and relapses? In this prospective multicenter study in patients with acute leukemia, 161 participants were randomly assigned either to the standard myeloablative regimen or to the same regimen plus ATG at a dose of 10 milligrams per kilogram of body weight for 3 days before undergoing allogeneic peripheral blood stem cell transplantation from an HLA identical sibling. After 24 months, the incidence of chronic graft versus host disease was 68.7% in the standard regimen group and 32.2% in the ATG group. The groups were similar in rates of relapse, infectious complications, and overall survival. The fact that relapses and infections were not increased with ATG was a happy surprise, since it was thought that reducing T cells with ATG might also lessen graft versus tumor effects and make the patients more susceptible to infection. The authors conclude that the addition of ATG to the standard myeloablative regimen before allogeneic transplantation resulted in a significant reduction in chronic graft versus host disease without increasing infections or relapses. Full trial results are available at nejm.org.
Methods: we conducted a prospective multicenter open-label randomized phase 3 study of ATG as part of a conditioning regimen. A total of 168 patients were enrolled at 27 centers. Patients were randomly assigned in a 1-to-1 ratio to receive ATG or not receive ATG, with a stratification according to center and a risk of disease.
My name is John Galvin. I'm one of the stem cell transplant doctors. My role is to see patients prior to transplant, help them through transplant, and afterwards as well to help manage any type of complication. GVHD is a complication that can happen after a transplant. It stands for graft versus host disease. The graft is a fancy word for donor cells, and the host is the patient cells. After the donor cells find their way and grow in the host or the patient, they can start attacking the host in places that it shouldn't be attacking.
I was aware of that GVHD may happen. I didn't know exactly what could happen to me. That's why I was watching closely to all the new symptoms that I was developing.
So graft versus host disease likes to attack certain parts of the body. The most common parts of the body that it involves would be the skin, and that can be anywhere from a small rash to covering most of the body with a rash. It can involve the gut, it can involve the mouth, it can involve the liver, and different forms of it can involve the eyes as well.
My graft versus host was mild. I had a red rash all over my body, but that was pretty much it.
I really didn't experience any real bad GVHD. Yes, I had the burning of the hands and feet. Yes, I had stomach issues for a little while, but those pass.
I had a bad GVHD in my lower part of my stomach, in the gut, which means I had to run to the bathroom multiple times a day. I also have GVHD in my mouth, which is a lot of mouth sores and tongue sores that are very painful. And lately I developed GVHD in my skin and in my eyes. So I had different types of GVHD, but they all can be taken care of with proper medicine. And if you just see the symptoms on time, you talk to your doctor and they give you a very good answer to what to do and how to take care of it.
The thing about graft versus host disease is it's something that is more treatable if we find it earlier. So if we suspect it, we can use medicines like steroids or to adjust the level of immunosuppression that the patient's on to suppress the graft versus host reaction and to get a handle on it before it becomes worse. So even though it might develop, and it's very common that we do see graft versus host disease, so we're never surprised, but we want to get it under control very quickly. And it is very treatable usually if we do find it early and treat it right away.
I think maybe I had the attitude that, this affects everybody else, not me. And looking back on it, you can't have that attitude. GVHD shows no boundaries, no mercy and everything, but it's something you learn to cope with. You can't let it get to you. You just have to say, I'm going to overcome it.
One thing you may hear your stem cell transplant doctor say is that they don't mind to see a little bit of graft versus host disease. And the reason why is that we know after you get a transplant that one of our concerns is that the transplant is working, that it's keeping your disease away. And when we see a little bit of graft versus host disease, we know that your graft or your transplant is active and is working. And if we see it affecting the skin a little bit, we can control that. Or if we see a little bit of symptoms in the mouth, you may not even notice it, but we can treat it or keep an eye on it. And we have the security, or a little bit added security, knowing that your graft or your transplant is working to keep the disease in check.
But the good thing about it is that the graft versus host is the fight between your cells and your donors. And you want the donor cells to win.
Results. After a median follow-up of 24 months, the cumulative incidence of chronic GVHD was 32.2% in an ATG group and 68.7% in the non-ATG group. The rate of 2 years relapse-free survival was similar in the ATG group and the non-ATG group, as was the rate of overall survival. There were not significant between groups difference in the rates of relapse, infection, complications, acute GVHD, or adverse events.
As you learn about or plan for a blood or marrow transplant, your transplant team will help you learn about GVHD. GVHD stands for graft versus host disease. Learning about GVHD and knowing the signs and symptoms to watch for can help you be more prepared for your transplant recovery. What is GVHD? GVHD is a common side effect of an allogeneic transplant. An allogeneic transplant uses healthy blood-forming cells, also called stem cells, donated by someone else. GVHD develops when your new donated cells do not recognize your body, and as a result, your body is attacked by your new cells. GVHD can range from mild to severe, or in some cases, it can be life-threatening. GVHD may be temporary, or it may be a disease that you continue to have long after transplant. If you develop GVHD, your doctors will provide treatment and help ease your symptoms. There are things you can do to lower your chances of developing GVHD. The first tip is to take your prescribed medicines and to continue taking them even if you feel healthy. The second tip is to be alert for any warning signs and tell your doctor about any changes in your body that you see or feel. Your transplant team will give you a list of signs and symptoms to watch for. Sometimes primary care doctors or hematology-oncology specialists may not know the symptoms of GVHD. It's important for all your doctors and transplant team to talk to each other and share information about your health. If you're concerned about a new symptom, it's okay to ask your doctors to check in with each other. Your health is their top concern. The third tip is to avoid exposure to the sun. The sun's UV rays may trigger GVHD or make it worse. If you go out, make sure you always wear a hat, sunglasses, long sleeves, and pants. Also apply SPF 50 sunscreen to all exposed skin. You may also want to wear SPF clothing for added protection. And always remember that the sun on a cool and cloudy day can be just as damaging as on a hot and sunny day. The treatment for GVHD works well for many patients. However, you may need to be treated for weeks or months. This is because it can take time to find the best medicines for you with the fewest side effects. While GVHD is serious, there are treatment options, and early detection is very important. If you have questions about GVHD, talk to your transplant team, who together with Be the Match will be there to guide and support you every step of your transplant journey.
The rate of a composite endpoint of chronic GVHD-free and relapse-free survival at 2 years was significantly higher in the ATG group than in the non-ATG group. And conclusions. The inclusion of ATG group results in a significantly lower rate of chronic GVHD after allogenic transplantation than the rate without TAG.
Hello, my name is Dr. Shahrukh Hashmi. I'm a consultant here at the Mayo Clinic Transplant Center and also the director of the long-term follow-up clinic here within the Blood and Marrow Transplant Division. Graft-versus-host disease is a rare disease. It happens as a complication of bone marrow transplantation, which is equivalent to stem cell transplantation. What happens is that the immune cells of the donor, they recognize your body as a foreign tissue, a foreign organ, and they reject your body. What causes this? What are the risk factors? It's very complicated. Briefly, few risk factors we recognize include a gender mismatch. For example, if the donor is a female and the patient is male, that can cause an increased risk of graft-versus-host disease. And then certain genetic matches which are important for transplant, if they're not perfect, they can cause graft-versus-host disease as well. There are different types of graft-versus-host disease with different presentations. There's the acute graft-versus-host disease, which happens within few months of transplant. There's a chronic graft-versus-host disease that happens after a few months of transplant. It can happen after 1 year or even 2 years of transplant. And then there is a new category called overlap type of graft-versus-host disease, which has features of both acute and chronic graft-versus-host disease. The acute graft-versus-host disease, which can happen within few days, few weeks, or within, for example, 3 to 4 months of transplant, usually presents with the involvement of the skin, the GI tract, or the liver. Now, the chronic graft-versus-host disease is a unique disease that happens as a late complication of transplant and resembles a disease known as lupus. It can affect any organ system. For example, it can affect the eyes. Patients can have very dry eyes, which can lead to blindness. It can affect the mouth, causing dry mouth, difficulty in swallowing. It can affect the GI tract, cause persistent nausea, vomiting, diarrhea. It can affect the liver. It can cause scarring in the liver. It can affect the skin, sometimes, which can cause shiny skin or plaques on the skin, sometimes the joints. Now, it's important to differentiate between different types of graft-versus-host disease since the treatments are slightly different. Both acute and chronic graft-versus-host disease are very hard to treat. Once they become severe, treatments don't work. We have been doing stem cell transplants for the past 50 years, and yet we don't have a single medication approved in the United States for the treatment of graft-versus-host disease. Corticosteroids, for example, prednisone, still remain the backbone of the treatment of graft-versus-host disease, both acute and chronic. With 450 transplants a year at the Mayo Clinic Rochester area alone, we are a big group of BMT physicians with at least 16 physicians dedicated to inpatient and outpatient management of transplant patients. Here at the Mayo Clinic, we have clinical studies for both acute and chronic graft-versus-host disease. We have a dedicated clinic which is responsible for the management, recognition of graft-versus-host disease and its complications. We generally see the patients within 3 to 6 months of a transplant. We hope that with this organized clinic, we're able to prevent the complications of stem cell transplantation. We're able to detect the graft-versus-host disease early in different organ systems and treat it promptly so that the patient's survival is better, and also, equally important, the quality of life improves.
The survival rate was similar in the two groups, but the rate of a composing endpoint of chronic GVHD-free survival and relapse-free survival was higher than ATG.
You mentioned what had been I guess, the really bad thing that people that transplant physicians worry about, this graft versus host disease. That's where your transplant essentially tries to reject you because it's your immune system. You've got a new immune system, right? I always thought that a little bit of graft versus host was probably a good thing, so you don't necessarily want a super perfect match. Is that fair, or has that thinking changed?
This is actually one of the most controversial areas in transplants today. So for the rare individual who has an identical twin, most of us would recommend the twin transplant. You're getting a pure product which has no contamination of cancer cells, and which there is a almost no chance of getting graft versus host disease.
No rejection.
No rejection in either way because it's an identical twin. There are some situations in which we do not like using an identical twin. For example, if people have active disease at the time of transplant, we need everything we can get to get that disease under control and keep it under control. So in that situation, you would say you want to try to get a little bit of graft versus host disease.
So not a real super perfect match,
Correct.
close.
But close, but again, it depends on what we perceive as the risk of relapse for a patient versus what benefit they may get. So for example, for chronic myelogenous leukemia, in which, just getting the donor cells is enough to prevent the disease from coming back, instead of using peripheral blood because there's two ways of getting stem cells from a donor. We can either go to the bone marrow and do 100 needle aspirations and get it straight from the source, or we can push those stem cells from the bone marrow into the blood and collect it like a blood transfusion. In one we call it a bone marrow transplant, the other one we call a stem cell transplant. It's the same type of transplant, it's the same cell. Except when we get it from the blood, we also get a large number of immune-fighting cells. So the price we pay at the end is that these patients have a higher risk of getting a late form of graft versus host disease that we call chronic graft versus host disease. But there's a beneficial effect for that, particularly for patients who have high risk for relapse because they were not in remission at the time of transplant. Their risk of having the disease come back is reduced by having a little bit of graft versus host disease. Unfortunately, we can't dial it in. So again, as I say, I want to get 2 notches of graft versus host disease or not, and we can't necessarily stop it very well when it happens. So when we decide what type of transplant to do for a specific patient, it depends on the type of the donor, whether the disease is in remission or not, and some specific, there's some cytogenetic abnormalities that we know are much more prone to relapse. And these are patients that say, look, you're going to need as much as you can get. Other types,
cytogenetic meaning the way the cell looks under
the
the
way
microscope.
the cell looks under, or special tests that Dr. Levine and Dr. Tolman have done. The other issue, and for myeloid leukemias particularly, is that Memorial has pioneered and developed a way of preventing graft versus host disease altogether, which is removing some of the immune-fighting cells from the graft, doing a process that we call T-cell depletion. In myeloid leukemia, this works very well because it allows us to give high doses of chemotherapy and radiation without as much toxic side effects, and it doesn't necessarily increase the risk of relapse later on. And what it does is it allows people to now not get immune suppressive drugs for the rest of their lives. Other types of leukemia, this process doesn't work as well, and we need to have the T cells are essential to keep the disease from coming back. So we really are now tailoring what is the type of transplant that a specific patient needs to get, give them the best chance of long-term disease control.
Thank you.